Good evening, everybody. I am presenting today this urinary tract infections in common and special situation. I am giving you first case of urinary tract infections. This was a 20 years girl presented to us with history of the 6 episodes of urinary tract infection in last 1 year. She had blood pressure of 140 by 86 millimeter of mercury. Routine examination urine revealed 8 to 10 WBC per high power field. Now her parents wants to go for marriage of this girl and no other investigations is in hand. So the patient asks about the safety questions about the marriage, and at this stage we do not know at all, like this boy does not know how to get water from this tube well. Urinary tract infection is an infection involving the kidney, ureters, bladder and urethra. When you look at the magnitude of this problem, urinary tract infection accounts for more than 7 million visits to medical offices and hospitals each year. It costs almost $1 billion per year and more common in adults than in children. In children, its incidence is almost 1 to 2% and more likely to be serious than those in adults. More common urinary tract problem in children besides bedwetting. In adults, female outnumbers male. Ratio is what 1:50, and approximately 50% of the women develop one episodes of urinary tract infection during their lifetimes, and 20% of women between the age of 20 to 65 years suffer one attack per year. We can classify urinary tract infection in different ways. One way of classifying is depending upon the parts of the urinary tract involved. If it involves prostate, it is called prostatitis. It involves urethra, urethritis. If it involves bladder, it is called cystitis. And if it involves the kidney, it may turn into acute pyelonephritis or chronic pyelonephritis. It can be divided into groups like the upper tract infections and lower tract infections. When it involves the kidney, renal, pelvis, it is upper tract infection. When it involves the lower tract, like it results into cystitis and urethritis. It can be classified as a simple uncomplicated urinary tract infection, or when you have the normal urinary tract, and it is called complicated urinary tract when there is some anatomic, functional or pharmacological factors that will dispose the patient to persistent infection, recurrent infection or treatment failure. One condition is asymptomatic bacteria that is defined by 2 consecutive urine cultures growing more than 1 lakh colony-forming units of bacterial species in a patient lacking any symptoms of urinary tract infection. There is no symptoms, but there is growth of bacteria on culture. Asymptomatic bacteria in female, 2 urinary samples with more than 1 lakh colony-forming units. In male, if the patient is symptomatic, even the 10,000 of the colony-forming units may be called as urinary tract infection or asymptomatic bacteria. A screen only if bacteria has an adverse outcome. Either this is the short or long term, that can be prevented with antibiotics. Otherwise, there is no need of a screening of the asymptomatic bacteria. What are the risk factors for the complicated urinary tract infection? These are the structural and functional abnormality, like the patient has enlarged prostate, calculi, obstruction, catheter, neurogenic bladder. The patients might have some metabolic or hormonal disorders that used to occur in diabetes and pregnancy. And if the patient has some immune defect, like the renal transplant recipient, neutropenic patients and HIV patients. Complicated urinary tract infections, usually the agent factors are usually virulent and usually Enterobacter C, usually reported in at least 1/3 of the cases. Pseudomonas aeruginosa, a cyanobacter, are common among the organisms. Methicillin-resistant Staphylococcus aureus, Enterococcus, Candida species, and other fastidious organisms are possible. Infection may be polymicrobial. There might be the growth of two or more organisms altogether in complicated urinary tract infection. It usually occurs. There are usually two important factors for the development of urinary tract infection. There is one host factor and agent factors. When you have structural, functional, or pharmacological problems, or some genetic predisposition for the urinary tract infection, these are the host factors. Either this is present, or sometimes the organism is so virulent that the patients can have infections. Like if the organism has more adherence, growth, and resistance to the host defense, these virulent factors may predispose the patients for urinary tract infection. Very young infants, bacteria gain entry to the urinary tract via the bloodstream from other sites in the body, and children of all ages, a sign of an abnormality in the urinary tract. If the children have urinary tract infection, we must evaluate the patients for the abnormality of the urinary tract. Symptoms varies depending upon the involvement of the tracts. When there is a lower tract involvement, lower urinary tract, characterized by dysuria, increased frequency, urgency, agitancy, cloudy or bad smelling of the urine, and sometimes hematuria. And patients might have the lower abdominal pain. When the patient has the upper tract involvement like pyelonephritis, the patient has usually the very high grade of the fever, shaking, chills, rigor, nausea, vomiting. Patients might have the flank pains. Sometimes atypical presentations you may encounter depending upon the host factors. Newborns. Patients might have fever or might have hypothermia. Sometimes the patients poor feedings, presence of the jaundice. These are the symptoms, atypical presentations seen in your newborns. Infants, vomiting, diarrhea, fever, because they cannot complain of the dysuria, so usually these patients might have the nausea, vomitings, diarrhea, fever, poor feeding, not thriving. These are the atypical presentation. In children, irritability, eating poorly, unexplained fever, loss of bowel control, loose bowels, changing the urination pattern. These are all atypical symptoms. Then we should suspect in these newborns, infants, and children for the urinary tract infections. Elderly patient, again, you might not have any other factors, but the patient has altered mental sensorium. Then we should also suspect that the patient had urinary tract infection. Catheterized patients may have fever only, no other urinary tract symptoms. Quadriplegia. Quadriplegic patients particularly have fever and there is increased spasticity or autonomic dysreflexia has been seen in quadriplegic patients when they develop urinary tract infection. Urinary tract, the missing link, underdiagnosed in children below 5 years and immunosuppressed patient, and it is usually overdiagnosed in patients of the school girls. Urinary examination is important. Midstream urine or clean catch midstream urine is the most important samples for the cultures, or either it can be obtained by catheterization or suprapubic needle aspiration. Urine examination, usually presence of the leukocytes of more than 10 per ml. By deep sticks, by nitrite or leukocyte stress test, or a gram staining of the uncentrifuged urines also you can suspect that these patients are suffering from urinary tract infections. Urinary tract diversity, when you will see the macroscopy, you can see directly there are multiple bacteria, and when you have the stress test for the leukocyte stress, then or nitrite test, that we can obtain that these are the indirect tests that indicates there is the presence of some organism in the urine. Urine culture is the gold standard test. Suprapubic aspiration, growth of the bacteria on the suprapubic aspiration of even of the more than 2000 to 3000 coliform units per ml. Catheterized, from the catheterized girls, 50,000 coliform units per ml of a single urinary pathogens. And when you have the midstream urines, 1 lakh coliform units per ml of a single urinary pathogen is present in symptomatic patients. We should take precautions. The urine should be sent for the culture immediately. If not, it should be refrigerated at 4 degrees Celsius if you need time to send. Ultrasonogram is mandatory in the infant, young child, adolescent with first time diagnosis of acute pyelonephritis. It is non-invasive but operator dependent. Contrast enhanced CT scan. It gives superior resolution and sensitivity in detecting renal tract abnormalities and perirenal collections. Here you can see you might have renal abscess, here you can denote. And this also gives indicating severe urinary tract infection, particularly in diabetic patients, and the patients are predisposed for the papillary necrosis. Then they can CT scan easily picked up the abscesses and papillary necrosis. Micturating cystourethrogram, avoiding cystourethograms is mandatory in children below 2 years and in older children if there is acute pyelonephritis. DMSA scan, it gives you the hints of the involvement of the upper tract or presence of the scar at the kidney. That you can see donate that this is the protopenic area. There is the presence of the scar. This is usually seen in patients of the pyelonephritis. If the patient has recurrent urinary tract infection, we should get it done, and this indicates the involvement of the scar or reflux nephropathy. And it usually you should avoid during the acute episodes of the urinary tract infection. At least it should be done ideally after 6 months after the last urinary tract infection. Newer imaging modalities are the cyclic voiding cystourethograms, cyclic direct radionuclide cystograms, echo-enhanced voiding urosonography. These are the new modalities, but it is not available everywhere. These are the methods, new modalities by which we can also detect the sacrourethral reflux. Coming to the treatment part, this could be the medical, surgical or preventive strategy. Not all complicated UTI are equal. Metabolic and immune defects associated with urinary tract infections are usually easy to treat and may not relapse. A structural abnormality associated with urinary tract infection are often difficult to treat and frequently relapse and may require urological intervention. So a lot of fluids, if the patient has the normal renal functions, a lot of fluids should be advised. Empiric therapy must be broad spectrum with a definite therapy based on the culture and sensitivity. If the patient has not recently received a fluoroquinolone, is not from a long-term care facility, if the patient has come first time, then fluoroquinolone should be given. Levofloxacin, usually 500 milligram orally, or ciprofloxacin are reasonable empiric choice. If patient severely ill or coming from some long-term care facilities, after hospitalization from other hospitals, select broad spectrum empiric coverage with either cefepime, ceftazidime, imipenem, meropenem, and piperacillin tazobactams. Drugs must be adjusted for renal insufficiency. If patient severely ill and urine gram stain shows gram-positive foci, consider adding vancomycin empirically. Once culture and sensitivity available, switch to narrow spectrum as much as feasible. Most experts recommend 10 to 14 days of the total therapy, and European guidelines recommend stopping treatment 3 to 5 days after either elimination of the complicating factors. Urological evaluation in women with relapsing infections, history of childhood infections, stone or painless hematuria or recurrent pyelonephritis. We must suppose these patients to go for urological evaluation. In men, if most male with urinary tract infection, with possible exceptions, urinary tract infection associated with sexual activity, uncircumcised male and AIDS patient, Otherwise, most of the male patients should go for the urological evaluation. In male or female, signs or symptoms suggestive of a stone or obstruction is there, then they should go for urological evaluation. Surgical intervention, if obstruction cannot be quickly relieved or anatomical abnormalities are uncovered, then urological consultation is strongly advised. Intermittent catheterization is preferable to an indwelling catheter whenever feasible. The use of a sterile versus non-sterile technique with intermittent catheterization makes no difference in urinary tract infection rates. Patients with condom catheters have fewer urinary tract infections than those with a dwelling-in catheters. Candidates for the condom catheter must be alert and have intact skin. That we should take care of. Coming to some special situations like catheter-associated urinary tract infection is the most common source of the gram-negative bacteremia in hospitalized patients. Risk of bacteria is approximately 5% per day. Accounts for 40% of all nosocomial infections. Diagnosis usually depend 100 or more coliforming units per ml of the urine from a catheterized patient. Uropathogens are acquired exogenously via manipulation of the catheter or drainage of the device. And bacteriuria may be sometimes polymicrobial in this condition. If asymptomatic, there is no treatment except if the asymptomatic bacteria, patient is immunosuppressed after organ transplantation, patient at risk of bacterial endocarditis, and patients who are about to undergo urinary tract instrumentation. In these conditions, we should treat catheter-associated urinary tract infection. Otherwise, asymptomatic bacteria should not be treated. If symptomatic, antibiotic that cover potential nosocomial pathogens should be added. Mild to moderate infections, oral quinolones are sufficient, usually 10 to 14 days coverage. Severe infection and unable to tolerate oral medicines, then parenteral antibiotic should be given, may be necessary. Duration of therapy in severe infections usually 2 to 3 weeks. Prevention of catheter-associated urinary tract infection. Metal cleaning, antibiotics in the Foley's bag or systemic antibiotics are usually ineffective way. It should not be their practice. Effective measures are aseptic insertion, maintaining a closed system, avoiding obstruction or backflow. Particularly when you are shifting patient one place to other, it must be below the level of the patient so that there will be flow from the patients towards the uro bag. It should not be the reverse flow. Removing the catheter as soon as feasible. Bladder scanning whenever bladder distension is suspected may help avoid unnecessary catheter insertion. Preventive strategy in asymptomatic bacteria. Catheter should be changed periodically to prevent the formation of concretion or obstruction that can lead to infection. Prophylactic systemic antibiotics have been shown to delay the onset of bacteria in catheterized patients, but this strategy may lead to increased bacterial resistance. Pregnancy and urinary tract infections. Diagnostic criteria is usually the same. 1 lakh coliforming units of the bacteria per ml of the urine. 2 to 2% of the pregnancy are complicated by urinary tract infections. And if left untreated, 1/3 of these women develops pyelonephritis, that is the threat. And pyelonephritis usually leads to low birth weight infants and prematurity. So we should treat asymptomatic bacteria during pregnancy. Every pregnant woman should be screened for bacteria by urine culture at 12 to 16 weeks of gestation. Treatment of urinary tract infection in pregnancy. Asymptomatic bacteria should be treated for 3 to 7 days of antibiotics. Although amoxicillin or ciprofloxacin is frequently suggested as the agent of the choice, nitrofurantoin, trimethoprim, sulfamethoxazole, ciprofloxacin can also be used. And caution should be exercised in the 3rd trimester because sulfonamide compete with bilirubin binding in the newborn. Urine should be subsequently be cultured to ensure that this is not free from bacteria. Symptomatic persistent bacteria, if it develops pyelonephritis, this patient should be hospitalized. Initially, these patients would receive IV antibiotic therapy, 14 days course, followed by nightly suppressive therapy until delivery. Recent studies have shown that selected pregnant women with pyelonephritis can be treated with either outpatient intramuscularly administered ceftriaxone or orally administered cephalexin. Ceftriaxone is third generation parentally administered cephalosporin is suitable agent for inpatient treatment. Tetracycline and fluoroquinolone should be avoided in pregnancy. Urinary tract infection in men, common in older men with prostatic disease, outlet obstruction, urinary tract instrumentation, anal sacs, who are not circumcised and whose sexual partner is colonized with uropathogens. In men, unlike women, a urine culture growing more than 1000 colony-forming units of a pathogen per ml of urine is the best sign of urinary tract infection, and with a sensitivity and a specificity of almost 97%. Urinary tract infection in men, no consensus. Urological workup in men with urinary tract should be done. Young men with acute cystitis, 7 days treatment response. Urologic evaluation should be performed routinely in adolescent and men with pyelonephritis or recurrent infection. When prostatitis is the source of urinary tract infection, antibiotic therapy should be given at least 6 to 12 weeks, and in rare instances even longer, because it should be treated like the upper urinary tract infections, prostate infection. Prostatitis usually behaves like a pyelonephritis. Urinary tract infection in children, I am giving you one example. This was the 1-year boy who presented to us with irritability, fever, foul-smelling urine. On examination, the boy was febrile, systemic examination was normal, urine examination shows pus cells, and urine culture shown E. coli. Ultrasonogram, you can see here, it was normal. We have treated this patient with oral ceftriaxone followed by prophylaxis, but patient relapsed. Again, it was treated with nitrofurantoin, again relapsed. Treated with IV nitromycin followed by nitrofurantoin prophylaxis, patients become infection free. After 6 months, the patient underwent micturating cystourethrogram, and here we can see this. There was some reflux, and there was posterior urethral valve. Posterior urethral valve primary flagellation was done, and patient has been put on the nitrofurantoin prophylaxis for 1.5 years. Afebrile become afebrile after 2 months. Weight was 8.5 kg. Urine stream was normal, and further investigation shows normal renal functions, and routine examination microscopy becomes normal, and patient has been followed with the ultrasonograms, and DMSA scan at 6 months was normal. Indication of admission, particularly in all infants with urinary tract infection should be admitted. Older children, vomiting and inability to keep down clear fluids or medication. Not better after taking antibiotics for 2 days. Acute pyelonephritis and immunosuppressed patients like AIDS and transplant patients, these patients should be admitted or should be kept indoor during treatment. Medical treatment, usually trimethoprim, sulfamethoxazole, amoxicillin, cephalexin, cefixime, ciprofloxacin, nitrofurantoin. These are the antibiotics which can be used depending upon your center's culture sensitivity report. Despite appropriate intervention, 1 to 3% of the pupils with pyelonephritis die, and uncomplicated urinary tract infections usually had the good outcome. Usually, the sequelae of this are usually the hypertension. The patient has impaired renal function and may develop end-stage renal disease. Other important part of the urinary tract infection is vesico-uretary reflux. Abnormal flow of urine from bladder into the upper urinary tract is vesico-uretary reflux. When there is presence of the scar associated with the vesico-uretary reflux, it is called reflux nephropathy. That scar you can demonstrate on the DMSA scan. Genetic factors, usually in siblings it is seen in 30 to 50% of the siblings, in children 50%, and in some family autosomal dominant inheritance has been found, and candidate genes, PAX2 genes, AC gene polymorphism. Usually DD genotypes has 5 times higher risk than other genotypes. Hypertension usually seen in 5 to 30%. Plasma renin activity secondary to scars and focal area of ischemia usually leads to hypertension in patients of the reflux nephropathy, and it is the commonest cause of severe hypertension in children. Usually, when you follow these patients of the vesicular reflux, grade 1 reflux resolves in 83% of the patients. On follow-up, grade 2 resolves in 60%, grade 3 in 46%. Non-dilated ureter, if there is only simple presence of the reflux, there is no dilatation of the system, usually 80% it is resolved. And if there is dilated ureter, only 40% resolves. Rest 60% it persists. When you look at the medical versus surgical therapy, similar involution of the new scars and similar renal growth. Surgical group, usually in this study it has fewer episodes of pyelonephritis and similar episodes of cystitis. Medical and surgical, when you look into the majority of this, is almost equal outcome. Medical therapy, chemoprophylaxis, no reflux at 6 months apart, at 5 years of the age, or at least up to the 5 years of the age. Surgical indication, failure to medical management, or the patient develops the breakthrough infection. Regular follow-up cannot be ensured, and moderate rate of reflux in adolescent or young women approaching childbearing age. Prognosis, usually 4% of the reflux nephropathy patients go into ESRD. Progressive renal disease, if usually seen if you have the 24-hour urinary protein more than 1.5 grams, if renal dysfunction is present, hypertension is present, glomerulosclerosis is present, or interleukin 2 levels in urinary cytokines has been shown that these patients progress towards end-stage renal disease or towards the advancing renal failure. So women who complains of dysuria and pregnancy, treat with a short course of the therapy, follow up 4 to 7 days later. Asymptomatic, no further intervention. Symptomatic, urine analysis, urine culture, both negative, observe, treat with urinary analgesia. Pyuria, no bacteria, treat for chlamydia trachomatis. And bacteria plus pyuria, treat with extended course of the antibiotics. Management of the urinary tract infections, recurrent urinary tract infections, 3 treatment options. Either you can use the long-term low-dose prophylaxis, usually 6 to 12 months, by sulfamethoxazole, trimethoprim or trimethoprim, naproxen 20, or norfloxacin, or post-intercourse low-dose prophylaxis. If some of the females are very prone for developing urinary tract infections, post-intercourse, in that it is self-administration, self-treatment is advisable, and they can take the, after every intercourse, you can take the single dose of antibiotics. And self-treatment and diagnosis, 3 days. Usually if the patient has a recurrent urinary tract infection, for 3 days course. If there is no urinary tract abnormality, then they can take the medicine, self-treatment at home for 3 days with this normal antibiotics like the fluoroquinolones or trimethoprim, sulfamethoxazole. Postcoital antimicrobial prophylaxis regime for women with recurrent urinary tract infections is usually effective. When you will look at the immunoactive prophylaxis, bacterial vaccine has been seen in the roles. OM89, Urovaxoma, is sufficiently well documented and has been shown to be more effective than placebo in several randomized trials. In a smaller phase 2 study, Strovac or Solco Urovac has been shown to be effective when administered with a booster cycle of the same agent. Both the immunotherapeutic products such as Urostims and Urovac, no control studies are available, so no recommendations is possible in present scenario. But these are some of the randomized control trials. They have shown, they have documented some benefit and effectiveness. Euroimmune is commercially available bacterial vaccines. The vaccines contains 2 vials containing suspension of 109 inactivated whole bacteria per ml, and the vaccine is a mixture of equal amount of selected strains of the E. coli, Klebsiella pneumoniae, Proteus vulgaris, and Enterococcus faecalis. And delivery route is usually the sublingual mucosa. Dose is usually given in forms of the puff, 2 puffs of 100 macroliter each. daily avoiding the concomitant intake of the food and beverage, and delivered dose was maintained under the tongue for a period of 1 to 2 minutes and then swallowed. The patient in group A, this study, received the treatment during a period of 3 months. And here we can notice that those who have received this Euroimmune, this bacterial vaccine, had fewer urinary tract infections as compared to those who were on the standard therapy. Prophylaxis with probiotics is also in practice. Lactobacillus rhamnosus, Lactobacillus reuteri, RC14 product is now available. Intravaginal probiotics that contain GR1 and RC14 for the prevention of recurrent urinary tract infection once or twice weekly as a prophylaxis has been shown to be effective in some of the study. Cranberry juice that we encountered in the literatures, that cranberry comprise, mostly it contains the 90% water, but also contain various organic substances like quinic acid, malic acid or citric acid, as well as glucose and fructose. Quinic acid cause large amount of hippuric acids to be excreted in the urine, which then acts as an antibacterial agents. There are two components of the cranberry. One is the fructose, which inhibits adherence of the type 1 fimbriated E. coli, and other is proanthocyanidins, which inhibit the adherence of fimbriated E. coli. So it acts in the many way. Hippuric acid has antibacterial property that is excreted in the urine, and it prevents the adherence of the, and fructose prevents the adherence of the bacteria to the uroepithelial cells. So this, in this way, cranberry is effective. But the tolerance is again the problem with the cranberry. Despite the lack of pharmacological data and the small number of quick clinical study, there is evidence to suggest that cranberry is useful in reducing the rate of lower urinary tract infection in women. For everyday practice, the daily consumption of cranberry products giving a minimum of 36 mg per day proanthocyanidin A is recommended. Estrogen for preventing urinary tract infection in postmenopausal women has been observed based on the only 2 studies comparing vaginal estrogens to the placebo. Vaginal estrogens reduce the number of urinary tract infection in postmenopausal women with recurrent urinary tract infection. However, this varies according to the type of estrogen and treatment duration. To conclude this session, urinary tract infection is a common infection. Early diagnosis is important. Prompt treatment is important. Nephrology consultation is must. All children with the first episodes, completed urinary tract infection and current urinary tract infection should go to nephrologist. But we must remember, 5 years after you finish your medical school, everything you were taught will be wrong. But if you wait an additional 5 years, it would be right again. Thank you. Thank you for your patience.